Okay, guys, yeah, welcome to the Global Medical Physics Education Lecture Series. We're very fortunate to welcome back Dr. Wendy Siman from the University of Colorado and Schutz Medical Campus. Simon has expertise in nuclear medicine type applications. He did his PhD at MD Anderson with Chinu Kapadath and has been practicing nuclear medicine along with diagnostic imaging physics for the last 10 years or so. But yeah, we're very lucky to have him back giving another lecture. This one specifically on image-based dosimetry. So I'll turn it over to Simon and we'll be happy to hear what he has to say.
Yeah. Thanks everyone for making time and coming. I know some of you live pretty late during the day like right now, but hopefully you can learn like a thing or two. So today we're going to discuss about like image-based dosimetry. So we'll look at just the concepts like from a very high level perspective, and I will take reference with Y90 therapy. So don't get to hang up on the specific application. I'm going to discuss it a little bit, but I want you to focus more on what image-based dosimetry is, why we do it and how we do it, and the challenges in doing it. So what is dosimetry? So dosimetry is a measurement or calculations of radiation absorbed dose by tissue, and it's per unit mass. So if you look at the unit, it's gray. This is the SI unit, is 1 joule per kilogram. So really what it is energy imparted per unit mass. You can think about it as energy concentration, but in terms of like the absorbed dose. So why is dosimetry important? Why do we bother? What you see here is the graph. On the x-axis is dose, and the y-axis is odds or like probability, and the left curve here is tumor control. So if you look at the blue left curve here, as you increase the dose, right, the chance of controlling the tumor, or in other words, kill the tumors, increases. And at the same time, if you look at the red curve here, this is chances of normal tissue complication. So, as you increase the dose, you increase the chance of both, killing the tumor and damaging the normal tissue. So that's why, it's important for us to calculate, the dose so that we can optimize for the treatment planning. And this is called the therapeutic window. So you want to be in the dose level whereby tumor control probability is high and normal tissue complication is low. So I'm just showing here on the left side here. This is from Y90 image-based dosimetry. You can calculate, and that's the tumor there. You can try to plan what the tumor will be. And then on the right-hand side here, for Y90, we worry about dose to the lung, and you can calculate the dose to the lung as well. Or sometimes it's to the colon or what have you. But the idea here is that we try to do like a precision medicine in radionuclide therapy or radiopharmaceutical therapy. So again, the idea is that you calculate both the dose to the normal tissue and the dose to the tumor, and you try to balance it. And some success story from yttrium-90 microsphere therapy. So the chart, the curve that you see here is a Kaplan-Meier curve. On the x-axis here is the durations or like times elapsed since therapy. And on the y-axis here is the portion of survival. So the blue one here, this is a standard care. So this is a palliative care without radiation therapy or radiopharmaceutical therapy. And the red one here is the curve for patients that receive radioembolization, or that's the RPT. And you can see that patients that receive radiopharmaceutical therapy have an increased or prolonged survival. And how do we know how much to give to the patient? That's where the dosimetry is coming in, right? So at the beginning, Y90 was designed to just do palliative care, meaning that the patient is terminal, and you just try to make them comfortable, right? So as we do this, then it's shown that apparently Y90 cert, right, like as you can see from the Kaplan-Meier here, found to prolong survival. And then furthermore, it's found that if you hit the tumor with a dose with a certain threshold, in this case is 110 gray, then the tumor is more responsive, meaning that they shrink and it prolong the survival. And that's why the idea of why we are interested in doing dosimetry. So in nuclear medicine, normally when we talk about dosimetry, we are thinking about internal dosimetry. So, we're interested in mean absorbed dose to the target organ. So what I mean by target organ is that when you inject a radiopharmaceutical, right? So, let's say it has a so, there's a sensitive organ that you try to protect during the treatment planning. And the source in this case can be renal. So, you have target and source, and this is the equation, and let's break it down really quick, D here is the mean dose, and then A is the cumulative activity. What it is that it's a time integrated activity. And if you look at the unit, it's megabecquerel times hour. Megabecquerel or becquerel is disintegrations per second. And when you multiply the disintegration per second by unit time, it gives you a total amount of disintegration. So the first terms really is just how many disintegrations that in the source that happen during the time. So the second factor is called dose factor, and this has a unit of milligray per megabecquerel hour. So the first term, this is a pharmacokinetic, right? You get this from the biodistribution, basically. How much activity stays in the source organ and then for how long. So, once you get that information, you can calculate how many disintegrations that happen, right? And then the second part, really, this is a physical attribute. The first one is the radionuclides. So, for a specific radionuclides, let's say in this case, I'm showing lutetium. You have the decay scheme, right? So you have the probability or the yield, and then you have what type of radiations beta particle and gamma here. So you have all that information, and it also take into account the target and source dimension, attenuation, and mass. So in this case, for nuclear medicine, based on the MERT schema, we use what we call the electronic phantom. So there's two electronic phantoms shown here. So these are not patient specific. This is kind of a representative patients, just some model. So once you have all these informations, the physical attribute of the radionuclides, the energy, the yield, and the type of radiations, and then the target and source geometry, the dimension, attenuations, and mass, you can calculate, how much energy actually escape the source and goes to the target per disintegration. And then on the left hand side here, we discussed that this is how many disintegrations, right? So when you have the number of integrations and you have the energy that's being deposited per disintegration, you multiply the number, then you get the dose, the mean absorbed dose. So this is per target source. So let's say we calculate for target bone marrow, source is kidney, right? And then let's say there's another source after kidney, it goes to the bladder, then you have to calculate again bone marrow, target, and bladder source, and you can keep doing it from liver and what have you, and you add all the number, then you get the total dose in your target from all the sources. So that is the MERT internal dosimetry, right? So what we want is a personalized dosimetry. I'm going to discuss with you, why we're interested in personalized dosimetry. But let's see what's the difference first. The first one is geometry. So the Olinda or the MERT schema use a standardized phantom. So it's the phantom that I showed you earlier. It's a electronic phantom for a model, just a model human. Whereas a personal dosimetry needs to be a patient specific. So, like an image of the patients or like the model of that patients. And resolution MERT base is organ level. It doesn't make sense to go to the tumor since, this is a model, right? Like, let's say like you're interested in the tumor in the liver, and then you cannot do it with the MERT schema with electronic phantom because, it's not even the patients, right? Like, all you can do is assume that, hey, this is the dose to the liver, but that's about it. Like, it's ridiculous to assume that, okay, the tumor is here or the tumor is there because it's not even the patients, right? And for personalized dosimetry, you can look at the organ dose, you can look at like a sub-organ, or even like at voxel level. So activity distribution. In MERT schema, you assume uniform distribution in organ. So, like you do not make distinction, like, so for example, like, in the dose distribution in renal, right? Like, or in liver, you have to assume that it's uniform. Whereas in personal dosimetry, it can be heterogeneous based on like your input, what's actually happening inside the patients, right? And the input function for MERT dose, you only need to enter the activity. So for example, you're treating with lutetium, right? So all you need to do is you input the activity, the injected activity here. The time integrated activity per organ, usually in this software, it has it tabulated already for like, a typical patients. Again, it makes an assumption that, like it's a typical patients or model patients with a typical biodistribution. And in personal dosimetry, you need to know like, what the actual biodistribution, and you have to do it with, time series quantitative imaging. And the output, again, like, mean dose, and the output in personalized dosimetry, you can get like, 3D dose map, you can do like a volume base, or you can collapse it to dose volume histograms, which I'm going to discuss later. And the tool is just like a different software that, like it's available. So clinical use, internal dosimetry, it's okay for regulation and for diagnostic. And for first pass, it's acceptable. So, like normally in diagnostic, right, like the dose is very low. So, like let's say like, for discussion sake, threshold for tissue complications, let's say like 2 gray, right? Most of the time you're calculating is not even half a gray. So, like in this case, if you're off by like, factor of 2, it still doesn't matter. Whether as for, personal dosimetry, let's say like, you do a tumor or like, radiation therapy, right? Then, like the difference of like, factor of 2 is not acceptable. So you have to be more specific on the personalized dosimetry. Again, tumor dosimetry is not feasible with MERT dose, and it's feasible with personalized dosimetry. The pro of using MERT dose is that it's very simple. So it's very simple, very reproducible. Whereas the personalized dosimetry is very complex. So you have like, 10 different people do it, you get like, you may get 10 different answers. So accuracy, again, is acceptable for diagnostic study or for radiation protections, and accuracy for personal dosimetry. If it's done right, it can be high, but like if it's done wrong, then the error will be very high as well. So why are we interested in personalized dosimetry? Again, like this is a Kaplan-Meier curve. So again, like this is the time elapsed time versus overall survival. The red one here is standard dosimetry per package insert. So these still involve some personalizations, but at the very rudimentary, very basic personalization versus like the blue curve here. This is a true personalized dosimetry on image base. You can see that the patient is responding much better. So that's why like, we need the personalized dosimetry. And we've been, well, I've been like, talking about Y90 quite a bit. And so let's like discuss what it is, like, really quick. So it is called the selective internal radiation therapy, or sometimes it's called the trans-arterial embolization therapy, radio therapy as well. So it is used to treat unresectable liver cancer. So the vehicle is biocompatible microspheres. So this does not have a biodistribution. It's just it becomes a permanent implant. So one, it goes to the destination, then like there's no clearance. And the payload is Y90 in this case. It's a pure beta emitter, and you can see like the statistic over there. So the mechanisms of the treatment is that in normal tissue, 70 to 80% of the blood is supplied by portal vein, whereas in tumor, because the angiogenesis, right, 80 to 100% of the blood is supplied by the hepatic artery. So, like you have like normal tissue that get blood supply from, like one from portal vein, and then the tumor from hepatic artery. So, like when you inject the microspheres that, to the artery, then the microspheres will selectively goes to the tumor. That's why it's the term is selective. So the distribution is mechanical. It flows like, the blood, and it flows where the blood vessels go. So in Y90 treatment planning, what we are going to discuss in the next few slides is different models of, personal dosimetry. And this is based on the work by Mert 29. It's just recently published last year. So the left images here, this is the true distribution, and this is a model, of course. Like, in patients, you never know what the true distribution is, and that's why we try to do the imaging and whatnot, right? So, like, again, this is just a model. So this is your normal liver, and this is the darker one is the perfuse liver. And the two circles here are the tumors, or supposedly like, tumor-like lesions in this case. So the first model is called a single compartment model. What it means is that, okay, we contour the perfuse volume, right, of the liver. And when we assume that the microspheres or the activity is uniformly distributed in that in this volume, and that's it. So, you do not see there's a tumor there. So the way you model it, you just acknowledge that there's like a compartment here, single compartment, and then everything is uniform there. So those again calculated as energy imparted per unit mass. And what information you need? One is that you need the lower volume, right? You can get it from the CT or MR in the pre-workout. And then the target dose, how much dose you want to hit this. For example, let's say like you're aiming for 110. So, you have the volume, hence the mass. So, you can make an assumption of what the density of the liver, right? You know the volume, the mass, and then what your target dose. So once you have that, then you can calculate how much activity you need to inject to the volume here. And the other information you need is Langshan fractions. So as I mentioned earlier, right, like, the microspheres, when you inject it to the liver, some of it goes to the lung. So you want to know like the portion of the microsphere that goes to the lung, so that you can calculate what's remaining in the liver. The strength of this model is that it's very simple, very reproducible. The weakness is that it's unrealistic assumptions to assume that like the microspheres is uniformly distributed in this perfuse volume. And this model is actually the standard care for like spheres, that is a glass microspheres. The package insert or like the vendor use this model to calculate how much activity that you need to inject. So now let's increase the level of personalizations, right? Earlier, we say that you have like a single compartment, everything is uniform. Now we add like more realism, if you will, to the model. Now we add the tumor here, and you can see like from here the density of the microspheres. So you assume let's say like this is the perfuse, right? So this is one volume, and it has a uniform distribution along that volume. And then you have the tumor. The tumor, let's say like, you assume like volume 2. And in this case, if it's dual compartment, you only have perfuse volume and tumor, that's it. So, in other words, you assume a uniform distribution in the perfuse volume. And there's even though there's two tumors here, you assume that both tumors have exactly the same uniform distribution as well. So, like there's only one and two. There's only two, and it's called dual compartmental model. And if you increase the realism again, it's called multi-compartment. So again, this is volume one, uniform distribution volume one, and then you have like one tumor, tumor two with different activity distribution, and then tumor three, or like tumor one and tumor two, like volume two and volume three. So like this called multi-compartmental model. So earlier we discussed what information is needed already, right? Like perfuse liver volume, we discussed it, and then the one that highlighted in red is the additional informations that you need to calculate with this increased personalization. So like as your model becomes more realistic, the task is more demanding, and you need further informations. And in this case, you need the tumor volume, right? And the tumor volume, again, you can get it from like a CT and MR. And then the TBR is tissue or tumor to background ratio. In this case, earlier with, single compartmental model, let's say like you inject like 100 millicurie to like 100 cc. All you need to do is just like, divide the activity by the volume, and that's it, right? And then with this model, because, you have like either 2 volume or 3 volumes here, if you inject 100 millicurie, you need to know like, okay, so what's the distribution like? And then, like that's given by the TBR. So, let's say like, tumor one is like 3-to-1 ratio, meaning that, it's 3 times as hot as the perfused volume. And let's say like, tumor 3 is like 4-to-1 or something like that. So that is like an increased demand from the imaging. You need an extra information. So for this, you need a quantitative spec, or like, PET, depending on what the imaging agent is. But, like it's relative, like quantitative diagnostic, it's very doable, because, like all you need to do is you draw the volume of interest in the tumor, and then you draw the volume of interest in the background, and you take the ratio, and you get the TBR. And again, the pro is that it's still simple, it's still repeatable, but the con is that even though it's more realistic than the single compartmental model, uniform tumor distribution is not likely. And the last model, this is the kind of like, the holy grail of the personalization. This is called like voxel dosimetry, or voxel level dosimetry, or sometimes you call it a 3D dosimetry, or personalized patient-specific dosimetry. So in this case, we do not make any assumption, and this is a true tailor-fit personalization. So we do not make assumption that, the distribution in the perfused liver is uniform. We do not make assumption that, like the tumor has a certain like, tumor to background ratio. However, we make a major assumption that the 3D dose map is correct. So which may or may not be true, depending on how you do it, but, there's error pertaining to it. So, the info needed now, we need, again, still like, segmentations of the normal liver, segmentations of the tumor. Long-term fractions now become optional. Tumor to background ratio is not relevant anymore, but, like what you need really is the dose distribution at voxel level. So the quantitative level needed is an absolute quantification. This is for therapy. So the pro is that it's theoretically the most accurate, because, you do not make any assumption of the distribution. However, the con is that, like we still assume that the 3D dose that, we calculate, or we derive, is accurate, right? And then, like it's been shown that, in multiple studies that, that people look at Y90, different group do it differently, and then the numbers all over the place. And that's what I call like, imperial grade. It's almost like, back in the day where people use like a length unit as like, feet, and whos, like, So before we dive deeper for image-based dosimetry, let's discuss really quick, or let's review the imaging that we're doing, PET and SPEC. And I did quick overview in my last Reddit sessions, actually. So, like Joe can point you out there. And then I think like, some other people have also done like quite a bit. So, like there's a lot of resources in the global medical physics. Anyway, SPEC, you're looking at a single photon. It's called, it stands for single photon emission computed tomography. So the signal that you're looking is gamma photons. And in PET, you're looking at 2511 keV. That's the annihilation photons. So PET is stands for positron emission tomography, and the positron is an antiparticle of an electron. So like once it gets emitted, it will recombine with electron, and it creates a positronium. It's unstable and eventually annihilate to like a 2511 keV. So detections method, SPEC use gamma camera with collimator. This is a very important part of the gamma camera. And PET use coincidence detections. So for gamma camera, right, like collimator construct, these are LED. These are LED, and then this is the interspace, and sometimes it's filled by carbon fiber. So suppose that your detector is down here. When you detect an event, right, you have to make assumption that it comes from normal from it, directly above it. And this is your line of response. So in this case, like if you detect an event over here, you have to place it above it, right? And, like in this case, like this is event one, this is event two. You can see that event one, the collimator is working properly and it placed the line of response, like, in the proper place. Whereas in event two, you have to assume that, the activity is somewhere along this line. And it creates an artifact because in this case, the gamma ray actually penetrate the collimator. And as you can see here, the star pattern here is the septal penetration. So in gamma camera, collimator plays like a major role in image formation. So for PET, we do not need the collimator. So what we detect is a true coincidence. Well, this is what you want, a true coincidence, but you detect coincidence and you have like scatter and random as well. So two annihilation photons, they go about at 180 from each other. You detect it here, you detect it there within the time window, and then this is your line of response, right? And of course, when you have like scatter, then the line of response get corrupted. And when you have random, the line of response also corrupted. But in PET, you do not need collimator. So resolution, SPEC tends to have lower spatial resolution, and PET tends to have higher. PET usually you can achieve like sub-centimeter. SPEC usually is still like in order of centimeter. Quantifications, PET is inherently quantitative primarily because all you image is this annihilation photons. It's always two 511 keV photons. Whereas in SPEC, like you can do quantitative imaging, but it's less precise and more variability. It's just because you have so many combinations, right? Like you have gamma photons that sometimes like 140 keV, sometimes like 200 something, sometimes 300, and then you have collimator low energy, medium energy, and high energy. And so like it involves a lot of like manual calibrations in order to achieve quantification. Availability, SPEC tends to be more widely available versus PET. Primarily because of like PET agents. Usually it's the radionuclides used have low half-life. So the radionuclides need to produce like somewhat locally. So corrections, you can do like a bunch of corrections. SPEC, both SPEC and PET, you can do attenuation corrections. SPEC, you always use CT, and in PET you use CT, or like more recently you can use MR for Atlas base as well. And then you do scatter corrections. You can do like random corrections for both, and then you do like a resolution recovery, spatial resolution recovery, and collimator detector response. So for hybrid imaging, SPEC CT and PET CT, all PET are hybrid imaging. So I've never seen a standalone PET, probably back in the day, but no longer the case. So all PET have either like CT or MR component, And SPEC still have a standalone SPEC, and then there's a SPEC CT that creates the hybrid imaging. So as I discussed earlier, the CT or the hybrid component of the CT serve two purposes. One is that for attenuation corrections. So both PET and SPEC, they do attenuation corrections, right? And the second importance of the hybrid imaging is the anatomical landmark. So, in this case, this is Y90 case as well. So you can see that, it looks like a liver, and then you see like another like, activity distribution that may be outside the liver. And when you do the fusion, apparently, it's still in the liver, right? So, you rule this out. Okay, so this is still in the liver. Whereas the one that's pointed by the green, it looks like, oh, it's part of the liver. But, like when you put anatomical landmarks to it, apparently the activity is closer to the colon. And, like in this case, it's a confirmed GI bleeding. So the CT and the MR for part of the hybrid, it creates a fusion imaging that gives you like anatomical landmark. Again, the same with this case, it looks like it's an extra hepatic distribution. And then when you fuse it with CT, apparently that's still part of the liver. So this is a false positive. So once we acquire the images, right, like, what we do with that. In nuclear medicine, the reconstructions is done by iterative reconstruction. There's like, different model, but, the essence is pretty much the same. So you have an object, right? You have an object, and then you acquire the images or the data, and then you rearrange the data. The data that you collect is in Cartesian coordinate, right? You have where it is, the location, X and Y, and then you have the intensity. And you can convert that to sinogram. Sinogram basically, you just like, change the coordinate from Cartesians to polar coordinate. So we create the sinogram on the data that we acquired. And then we start, the iteration starts here. So we assume an image. In this case, like you can start with a blank image or any image really. But once you have like a starter images or an image assumption, you can calculate the forward projections to create the sinogram. So this is the measured sinogram, and this is the calculated sinogram. And you can compare these two. So, like, and then once you compare, you get the feedback, right? Like, are they similar? If the answer is yes, then, like your image is reconstructed. And if the answer is no, then, you update the image and you update your starting imaging, right? And this is called like one iteration. And if you keep doing that, you get like one iterations, two iterations, three iterations, and, so on and so forth. And as shown, like, on the right images here, you get like iterations 1 till like iteration 10. So the more you iterate, then, the image start converging. So the earlier, when I say like, compared to image, like, do they converge? Are they similar? If the answer is yes, but, the question is that, like, okay, what metric do we use, right? Like, to say that it's converged, or to say that they're similar already. And this is your objective function. So you need to define your objective function. So let's say like, in diagnostic study, right? You need to know like, okay, this is used for diagnostic. What object am I looking at? Am I looking at, high resolutions, or like, a small object, or am I looking at big object? And am I expecting low contrast, high contrast? So that actually determines like, what the objective function is. And, if you want to do dosimetry, then you have to use an objective function that, that's different from diagnostic objective function. In diagnostic, you usually use contrast to noise ratio, or you use activity recovery percent, So those are fine for diagnostic, but for dosimetry, you need to use the absorbed dose. So whether it's mean or whether it's DVH based, then the objective function of the iterative reconstruction needs to match with the need, or how are you going to use the images, or like in other words, the imaging task, right? And why is that? Like, why do we need to create an objective functions, right? Hey, once I reconstruct the images, like, we get the proper image, right? The answer is not really, like, the reconstruction is full of artifacts. So in ideal world, when you reconstruct the images, you recover the object. But in this case, we never truly recover the images. So these are just some reconstructions artifact that I'm showing. So you can have like a special blur. So in this case, like the left one here, this is a collimator blur. So as the object move further away from the collimator in gamma camera, then your resolution is going down. Or in PET, you can have what we call depth of interactions. So basically, your detector has a finite size, finite elements, right? And then it blurs the resolution as well. You could apply point spread function resolution recovery. So the images that you see here, this is the truth. This is the reference images. And when you acquire the images here, you can see, like, the edge of it is kind of blurred, right? Like, the edge looks very fuzzy versus if you look at the edge of the actual object, it's really sharp versus here, right? Like, it's really fuzzy, right? Once you apply resolution recovery, then the edge looks a little sharper, but it introduces an artifact, right? Like, you see like the middle of it, like, the center part, it becomes like darker. So this is a ringing artifact. So the point that I'm trying to make here is that, you can try to correct for, like imperfections, but really what you're doing is that you're trading one error versus the other. Here we're looking at motion blur. So, like these are spheres, like, in a phantom, static case, sinusoidal motion with 1 centimeter, 2 centimeter, 4 centimeter. You can see how it degrades the images here. And, like to correct for motion, you can do gating or you can do data driven. With gating, you increase the noise because you're basically cutting off, the data, right? Or you either, like, end up with lower acquisition durations or higher total. Normally, like, the clinics will try to fix, the study time. So what end up happening is that you're trading the resolution with the noise. Or when you go to data-driven path, what it does is that, it combines all the data, so you do not lose data per se. So, like you still maintain the noise, right? However, with data-driven, you have to do what we call is it called again? Image registration, sorry. Image registration. And when you do deformable image registration, then you introduce another error. Again, the point that I'm trying to make is that, hey, you have like one error, right? And then you try to compensate it and you trade it with some other error. Here, I'm showing images of Y90, and it acquired for 5 hours. And this is a phantom study. You cannot acquire a clinical image for 5 hours. And this is more like, what you'll see in clinic, 20 minutes or like, 5 minutes towards the lower end. And you can see here that, at the sphere here is a uniform spheres, by the way. And when you acquire for 5 hours, yeah, it looks like a uniform sphere. So, like it's very respectable, right? But, like as you reduce the durations, you can start seeing that, the uniformity breaks down, right? And this at 5 minutes, this does not even look like a uniform sphere anymore. So again, this is a reconstruction artifact. So now let's discuss how we do image-based dosimetry, right? So image-based dosimetry, it puts a lot of emphasis of the images. So, like garbage in, garbage out, reconstruction images are far from perfect. And that's why we need to, when we reconstruct it, we have to keep that in mind and set the proper objective function, because not all images are created equal. Again, in ideal world, you can recover what your object truly is, then then you do not get an objective functions, but that is not the case. So like in post-therapy imaging, the task is not a diagnostic task, it is a quantification of volumetric dosimetry. So like you shouldn't use a diagnostic metric like SUV mean or SUV max, or like CNR. So clinical workflow in Y90, normally pre-treatment workup. So, like a disease eligibility assessment. So, I want to point out that, for Y90, for lutetium, RPT, usually the eligibility assessment are based on like, just safety. And this treatment normally is kind of like the last line of defense, where, like a chemo fail, like, other treatment fails, then, patient gets sent to Y90 or like a lutetium therapy, depending on like, what they have. And the case with Y90, right? Like, as we do dosimetry, then we start seeing that apparently, it prolonged life, right? And then for Y90, recently it's been shown that, like it even like, outperform or like perform just as good as chemotherapy or trans arterial chemical embolization. And the same trend I see in lutetium as well. So, like normally patients refer to RPT after they fail chemo, and then there's like a motions to push it like, to the front line. And that is thanks to dosimetry. And that's why like, we're discussing this, right? So next, it's pre-treatment planning. It's done with surrogate imaging agent. So in Y90, like, the therapy is done with microspheres, but the surrogate is MAA. And we need that for defining the tumors. As we discussed, remember, we discussed about the different models of Y90, right? You have like single compartment, multi-compartment, and you need all that information from the surrogate imaging agent. So, you can do it with either SPEC or PET, depending on your agent. And then you need to do it for multi-time point to establish the biodistributions to eventually end up calculating the time integrated activity. In Y90, this doesn't apply because Y90 distribution is mechanical. So, once it's there, then, there's no biodistribution. And then we use it to calculate the dose distribution, and this is for the treatment planning. The goal is to minimize normal tissue toxicity and then maximize the tumor control probability. So in other words, we're trying to find that therapeutic window. The next is the treatment delivery, right? And after treatment delivery, we need another imaging for treatment verifications. Now with the therapy agent. And the steps is actually just like a repeat here, except that, earlier we in the treatment planning, we image it with the imaging agent, and with the treatment verifications, we image it with the therapeutic agent. And treatment verification is very important for patient management, because like I've shown earlier, right? Like, let's say like, in Y90, if you have like a extrahepatic distribution, then you can intervene like, faster, right? You don't have to wait till like, the patients show clinical symptoms. And also for the tumor, as control probability, once you do the treatment delivery, you do the treatment verifications, right? You can see, okay, patients receiving like dose too low. And if that's the case, then, you can try to boost it with, let's say, like, external beam, or do like a second therapy without waiting for like, 2-3 months to see whether patients, are responding or not. And the last part is that, again, you do imaging again, and this is not the nuclear medicine. This is done with CT on MR to determine whether the patient is responding or not. And in this case, to see whether the tumor shrinks or not. So how we do image-based dosimetry? So let's assume that we have like a cylinder with a perfect, like a sharp edges, right? And if we draw the line profile across the cylinder with perfect reconstructions, the response will look like rectangular functions, right? So, like a uniform distribution activity in here, you image it and have like a perfect images, then you have like a very sharp images, like, a sharp rectangle function. So once you have the activity distribution here, you can either do Monte Carlo simulation, or you can use those voxel kernel, and this is based on Monte Carlo simulations anyway. So these two methods, it's like, pretty much equivalent, except like the dose voxel kernel is faster and is simpler. So you convolve it with the dose voxel kernel, and you calculate the dose map. So you get the dose distribution, and notice that the sharp edges in the activity distribution, once you turn it to the dose distribution, then it's kind of blurred, right? So the reason being is that if you look at the top curve here, this is for positron, but electron behaves the same way. So the point of origin is at the center, but you can see energy being deposited toward the edge as well, right? So you have to, and if you draw the line profile across this curve, then you get this plot over here. And again, where the activity is at the center. So in other words, both positron, and in this case, we're more interested in the electron, right? When it deposits its energy, there's distal energy deposition, and that's what creating this blurring over here. So in real case, when we do reconstructions, the reconstruction is not perfect, right? So the truth is that this rectangular function, and then what you end up reconstructing is this dashed line. So it's blurred already, right? And if you apply either Monte Carlo simulations to these distributions, or you convolve it with those voxel kernel, what you end up having is this curve over here, and this is the prime dose distribution, and the solid one, this is the truth. So as you can see here, the error over here, right? The error in your images, when you do image-based dosimetry, it's translate directly, the error propagates directly to the dose map. And this is why it's like garbage in, garbage out. So, a lot of people do not realize this and just assume that any images will do. I mean, that is not the case. So what's the alternative? The alternative, we can use what we call local dose deposition method. So again, if we go back to this line profile, right? And if you look at the intensity over here, about 90% of the dose actually deposited in this area. So it's really within 2 millimeter, plus minus 2 millimeter. So the idea of the local dose deposition method is that, hey, since the 90% plus of the dose being absorbed within a voxel, let's just multiply the voxel by a scalar multiplication. So in this case, what you see is what you get, the activity distribution, you multiply it by a scalar factor, it becomes the dose distribution, right? So what you're hoping is that the blurring that's done by the imaging chain mimic the blurring that's done by the energy deposition here. And so, this is best case scenario, but, that is not the case actually. For Y90, the kernel, full width half max of the kernel is around 3 millimeter, and spec resolution is 20 millimeter. And then the pad resolution have full width half max of 10 millimeter. So, our imaging chain actually blur it more than the actual dose voxel kernel. So again, this is local dose deposition method. You reconstruct your images and you multiply it by a scalar multiplication, and this is your dose map. And this method is used in all commercial dosimetry software, Simplicity, MIM, SurePlan, and then some European software as well. So the last thing that I want to discuss with you is about navigating this imperial gray. So for the next few slides, I will show you when you change the imaging or reconstruction parameter, then your dose distribution changes. So suppose we have a phantom, right? Like a uniform phantom with like a lesion here. So what I'm showing in the curve on the right-hand side here is called dose volume histogram. So on the x-axis, this is a dose threshold, and the y-axis is volume coverage. So how you read it is that, like for example, if you draw a line over here, 60% of the volume receive at least 150 gray. So that's what the chart means. And this is an attempt to collapse your three-dimensional or like four-dimensional dose map, right? Like you have like the locations and the dose intensity. That's a four-dimension data, and you try to collapse it to two-dimension only, right? The dose threshold and the volume coverage. Anyway, the first image here, 12 iterations. So that's given by this purple line. And notice that, like pay attention to the shape of the spheres. So at 12 iteration, they still look somewhat like uniform spheres, right? And then I increase it to 24. So the red one, red curve here is 24 iterations. It's getting closer to the truth. The black line here is the truth, but you start seeing that the uniform spheres start breaking, right? Now you have like a dark spot over there. And then if you increase it even further, and look at this, like so earlier that's what it looks like. You can see like hey, there's probably something like uniform here, right? But like as you keep increasing, it hallucinate the hotspot, and you increase the iterations again, like more hotspot. This is not real. This is also not real. But it's getting closer to the truth. So like the point that I'm trying to make here is that like depending on how you reconstruct it, the image looks different, and then the quantification looks different as well. In diagnostic, normally what you do is that you apply a smoothing filter. So like if you apply a smoothing filter, then you can kind of like smooth this out, and then like create like or introduce or increase the uniformity. However, let me show you. Okay, so this is what happened when you apply a smoothing filter. So this is a Gaussian filter, right? And what's shown here is the full width half max. So if I apply a 2.6 millimeter full width half max, I get a curve that looks like this, right? But as soon as I increase it, look at how it changes. So it starts shifting, right? And then if I keep increasing, it's shift even more, right? So the shape actually changes, like the shape of those volume histogram changes as you apply more smoothing filter. However, if you look at the spheres over here, right, that looks pretty good actually, versus if I don't apply any filter. Look at the these big spheres, right? It has like cold spots that's not even there, like it's artifact. But as you increase the filtration, it increased the uniformity. However, like your deviates is actually down here. So the point here is that like when you reconstruct for dosimetry, again, like your objective function has to be dosimetry. You shouldn't worry about like how the image looks, because like reconstruction is not perfect. If you want to if you want to reconstruct for visualization, then you create or you optimize it for visualization. And if you want to do the dosimetry, then you have to have like a separate reconstruction that's optimized for dosimetry. So like you do not, this is a retrospective reconstruction, right? So you do not have to have like one, okay, I just want like for dosimetry, that like I cannot use it for visualization. That is not the case. All you need to do is that you create another sets of reconstructions that allow you to better visualize it. And this is a signal density for Y90, and this is the same images that I show you earlier. So this is a 5 on the left side. Here is a 5-hour acquisition, and this is a 10-minute acquisitions. you can see like, you can appreciate how the image changes, like, from uniform to very like, it looks very clustered. And if you look at the volume histogram, which is like, what you need for quantitative dosimetry, the black curve, this is the truth. You image it for 5 hours. It's actually pretty decent, It's pretty close to the truth. And you image it for 10 minutes, then, like it gets further away from the truth. So, we have to keep this in mind because, sometimes all it takes is that, like for Y90, half-life is the 2 days. So, like all it takes is that, it's an afternoon patients. So if it's an afternoon patients, more than likely you need to image it the next day, right? So, whether you image it like, right away after 2 hours, after 3 hours, or you image it like 24 hours later, then, the curve will change. So, like, yeah, it increased like variability. Again, what I'm showing here, this is for motion blur. So what I did here is that, the black one is the static at 100%. And for the blue curve here, I reduced the count to 30%, 33% without anything else. I haven't changed anything. So just by reducing the signal density, then, your quantification changes. If you compare it with, let's say, like, I have like a minimal motion blur, right? 1 centimeter amplitude. It's actually closer to the truth, right? If you compare these two versus, like the black versus the blue. So in this case, like if you try to do motion corrections, it harms the quantification if you have like a smaller motion. But as the motion's amplitude gets bigger, of course, like, if you can correct for it, like, then correct for it. Yeah, this is the same. But anyway, why am I showing you this? So what you see here, this is a major clinical trial for Y90. And the curve the chart that you see here is absorbed dose versus response rate, right? And it shows like, this is a non-responder, partial responder, and this is a complete responder. And if you look at the x-axis, right, 200 to 300 versus 300, the difference here is only 100 gray, right? So if you look at, let's say, like, you come over here, and let's say, like, we're looking at the mean or like median. This is like, this is like already like, what? It's 50 gray already, right? So what the point that I'm trying to make is that, the variability because of like how you would reconstruct the images versus like, someone else reconstruct the images, the variability alone is already like, almost 100 gray, like, 50 to 100 gray. And then, like when you look at the clinical trial, so, like just because like how you reconstruct the images, you can interpret it. Oh, the patient is going to respond, or the patient is not going to respond. So, like yeah, this creates like, a big variability, and this is not because, like what's the patient's being treated. It's just like, how you image the patient. So last, I want to show like, challenges of SPEC versus PET for Y90. So PET have a very low signal for Y90. The signal is 32 part per million. And even with the latest digital PET, it's equivalent of injecting half a millicurie of F18. Normally for whole body, you inject like, close to 10 millicurie of F18. Or the other way you look at it, you image it for 50 seconds per bed position for whole body. And normally you do somewhere around like 3 to 5 minutes. So, like signal is really low. And when you look at SPEC is just not designed to image the bremsstrahlung. So Y90 doesn't have gamma emission. So what we're imaging is the bremsstrahlung. So, like it has a continuous spectrum and very high energy. So the energy goes up to like 2.3 MeV. And signal, it's better than than PET, but it's still pretty low. So, in other words, like in PET, what you're dealing with is a quantum noise. But in spec, what you're dealing with is the noise in terms of like engineering noise, like so unwanted signal. So like a pad, you don't have enough signal. In spec, you have a lot of like unwanted signal, and resolution is poor. So if you look, if you compare here, pad versus spec, you can see like the resolutions, right? In pad, you can still see that spheres. In spec, like it's gone already. And the bottom one here is the clinical case. PET, you kind of see a cluster over here, and in spec, it's kind of like just a haze. But the questions though is that like whether you can trust that this is a cluster or not, right? As I've shown like earlier in PET, because the image is so noisy, it start like creating like a hotspot artifacts. So in summary, like we discussed about the importance of dosimetry. So that lets you draw a relationship between dose response and dosimetry that you can use for your treatment planning and treatment verifications. And we also discuss about different dosimetry models from organ to voxel. As your models gets more complicated, get more realistic, then like it becomes more complex, and it introduces a lot of errors along the way, because of the complexity. And then the last thing is that we discuss about what the term that I coined as imperial dose in image-based dosimetry, meaning that like the way you do it will change, like the measurement. Like site A do it, site B do it, like it's totally different number. So in order to navigate that, when we do a study, we need to explain, like we need to put a detail on how we come up with the images and how we calculate the dose. It's not sufficient to just say, like hey, we do personalized dosimetry with spec base, and that's it. Like a lot of study done that. So like in that case, it is not reproducible because of the variability is high. And that's all I have. Thank you for your attention.
Yeah, thank you so much for that, Simon. I appreciate that. Hold on, let me